Yeah, it'll just be the exact same as my other YouTube videos. The only difference is now we have the video of me, which I don't like, but um, all right. So today we're going to be covering gradient echo pulse sequences, and hopefully that review game we had last week kind of refresh your memory, at least of just kind of the major concepts. If you don't remember the actual like definitions of those concepts, at least you were able to relate those things and kind of gave you a good refresher of what we went over the entire summer semester. But today we're going to be talking about gradient echo pulse sequences, but it's good to review the conventional spin echo pulse sequence for comparison reasons. So let's take a look at this pulse sequence diagram here and just kind of review the concepts. So our first line is always going to be our RF pulses. Our second line is going to be our slice select gradient. Third line is going to be our phase encoding gradient, which is typically the longer or shorter axis. The shorter axis, because we want to reduce our scan time equation, and phase encodings are part of the scan time equation. And usually the shorter axis, we align it with the smaller part of the anatomy so it doesn't wrap into our image. Have you guys experienced any phase wrap while you've been in clinic? A lot of times with MSK imaging, it gets a little tricky, especially with the coils maybe laying right up against the body, things like that. Our fourth line is going to be our frequency encoding gradient. What's another name for frequency encoding gradient? Readout, because that's when we are collecting the echo. And then our last line is going to be our MR signal. What is this little squiggly line right here? Free induction decay. And then we have that 180-degree refocusing pulse, and then our signal starts to rephase or regrow until we sample the signal at peak signal here, which is our TE. So with spin echoes, let's go over some of the advantages and disadvantages of a traditional spin echo. So our advantages are we usually get good image quality, because we have very high signal, and typically we have good resolution with it. It's a very versatile pulse sequence, and the contrast is based on true T1 and T2 relaxation times of the tissue, because we allow those tissues to decay almost completely and to recover almost completely. But the disadvantage with that, allowing those tissues to decay and recover fully, is that our scan times are relatively long. So we know in MRI imaging, typically we have to have patients sometimes hold their breath. With your abdomen imaging, have you guys experienced that? How long have you had them hold their breath? What's like the maximum amount of time? 20 seconds. Sometimes you usually want to keep it between like 15 to 20 seconds. That's typically what a normal patient can hold their breath for. You might be able to get like 25 seconds for a really good patient, but 20 seconds is almost your maximum. Have you guys seen some of those MRCP sequences where it's just like hold your breath and it's just boom, quick and easy, almost one shot, and then they do different angles of the biliary ducts? Okay, so you've seen that a little bit. So those are typically gradient echo pulse sequences because you're able to scan very fast, very rapidly. So the spin echo has relatively long scan times, and I'll show you why. So we are almost governed by how the spins dephase and rephase. So what is this pulse right here called again? Good. So this first RF pulse is our 90-degree excitation pulse. And why is it 90 degrees? $90 degrees from what? Our net magnetic vector typically aligns at the beginning with the longitudinal or transverse axis. Longitudinal. So we flip it 90 because we generally collect the signal on that transverse axis. So with our spin echo pulse sequence, we give it a 90-degree excitation pulse because that transverse axis is where we collect the signal, where we have that receiver coil. So we apply that, and then we allow once we turn it off, our spins start to dephase. So this time in red, from free induction decay to the 180, the spins are dephasing. Then we have that 180-degree refocusing pulse. So in green, from 180 to peak echo, the spins are rephasing. Or growing. So this is not typically drawn to scale on these pulse sequence diagrams, but these two should be equivalent. And sometimes I described it as 1/2 TE. And then the rephasing was 1/2 TE. So you can see we are kind of governed in spin echo by how fast the spins dephase and how fast they rephase. So that's why your time is limited on how low we can go. Another thing I want you guys to notice about our spin echo pulse sequence is this slice select gradient. This slice select gradient is turned on any time an RF pulse is turned on. This factors in when we start to talk about flow, blood flow. Because a spin echo pulse sequence sometimes is unable to catch flowing blood within the arteries and the veins, where it has to excite it and refocus it, and so you don't actually get signal in blood flow on those pulse sequences. You get what we call a blood flow void, so there's going to be no signals within those vessels. But on a gradient echo pulse sequence, we do not have this 180-degree refocusing pulse, so it's not going to be slice selected, and we actually are going to be dephasing and rephasing with our gradients. So no matter where that blood flow starts and ends, we're able to rephase it, and we actually get signal from flowing blood on our gradient echo pulse sequences. So that's why gradient echo pulse sequences are beneficial when we're doing angiography. So our MRA scans are typically going to be our gradient echo pulse sequences. All right, so let's scroll down to now our gradient echo pulse sequence and show you the difference. Okay, so here's our gradient echo pulse sequence diagram. And here we have that first RF pulse. Is this still called an excitation pulse, do you think? It is. But what's different about this excitation pulse? Not 90 degrees. So less, typically it's going to be less than 90 degrees. Sometimes they draw it and they'll have it labeled on your test as, when it's less than 90 degrees, as this alpha signal. So make sure you know this typically means you have a variable flip angle, meaning less than 90 degrees. Our second line is still our slice select gradient, and you can see that it only turns on during that initial excitation pulse that is less than 90 degrees. You do not have that 180 degree refocusing pulse, so it's not slice selective when in terms of refocusing our spins. What refocuses our spins is this down here on our frequency encoding gradient. We actually dephase the spins first, and then we rephase the spins. So this section on your pulse sequence diagram is actually equivalent to the first half of our readout gradient. So first, with the frequency encoding gradient, it dephases the spins, and then it rephases. So our gradients are doing the dephasing and the rephasing, not that 180 degree refocusing pulse. So what do you think the benefits of having gradients do it versus the 180 degree refocusing pulse? Why do we use gradient echoes versus spin echoes? What's the main reason? Faster. It's faster. You can turn those gradients on at any time, at any amplitude, and at any polarity. So you can, this little box can be an increase in amplitude, and it can occur almost right after your excitation pulse if you want it. So the timing of the pulse sequence can be controlled a lot more by the operator. So we can time our gradients so that we maximize our speed for the pulse sequence. What is a disadvantage of not having that 180 degree refocusing pulse? What's a disadvantage? What's so good about that 180 degree refocusing pulse? It corrects for a lot of things. Good. Chemical shift, magnetic susceptibility, and field inhomogeneities. Remember why you typically shim your magnet? You want the field to be as homogeneous as possible. So that 180 degree refocusing pulse does all those things. The gradients are less efficient at doing that. So that's why if you had a patient with metal in their knee, you're going to want to choose a spin echo pulse sequence versus a gradient echo pulse sequence because it doesn't correct for that metal susceptibility artifact as good. But take notice at this pulse sequence diagram. It is very similar to your spin echo. The only difference is you have a variable flip angle to start, and you're using gradients to dephase and rephase the pulse, the spins. You still have your slice select gradient, you still have your phase encoding gradient, which you're changing each TR, and then you still have your signal decaying and then regrowing, and you're sampling at time TE. So there's not that much difference in the design of the pulse sequence. It's just that we're using gradients to refocus the spins compared to a 180 degree refocusing pulse. So let's write out the characteristics of a gradient echo pulse sequence. Let me increase the size here. What do you think GRE stands for? I keep typing that, but I was waiting for somebody to ask what GRE stands for. It stands for gradient recalled echo. So the gradients are rephasing the spins So they're recalling the signal. So GRE stands for gradient recalled echo. You might just see GE for gradient echo, but most of the time you're going to see GRE, gradient recalled echo. All right. So the first characteristic is we have no 180 degree refocusing. Let me pulse. An advantage of that, we can reduce time. A disadvantage of that, we can say it does not correct for field inhomogeneity, metal susceptibility artifact, and the last one that Rachel said, chemical shift. Our second characteristic, don't have to wait for dephasing and rephasing. This is a function of how strong the gradient magnetic fields are as well as how long you leave them on. So with spin echo, you had to wait for it to decay, that free induction decay. Let those spins decay. Took about 20 milliseconds on a T2 weighted sequence. Then we applied that 180 degree refocusing pulse. It allowed all those spins to go back coherent. And that took the same time, 20 milliseconds. And then you sampled the signal. But with gradient echo pulse sequence, we could just turn on our gradient real strong, dephase them real quick, and then turn it on in the opposite polarity and rephase them real quick. And boom, that's only 5 milliseconds compared to 40 milliseconds. So we don't have to wait for the spins to naturally decay and rephase. Because remember, all tissues decay and rephase at different times. So we can control it a little bit more. So, an advantage of this, we can compress our pulse sequence. We could reduce our TR and we can reduce our TE. Which one's part of the scan time equation, TR or TE? TR. The only disadvantage I can think of for this is some scanners don't have this capability. But most of the scanners you're working with in clinic do. The only one I could think of is maybe that Hitachi at Roswell. Number 3, in a given TR, what's TR stand for? Repetition time. We can actually excite more slices. So if you've worked on a scanner and you've seen that little pop-up box, you've reduced your TR and you're like, ooh, I've reduced it as much as I can. You're ready to start your pulse sequence, and then all of a sudden it gives you this pop-up box. And it says our SAR limits have been reached. We either need to increase the number of reduce the number of slices, or change the flip angle, or what's the other option they give you? Change your TR, exactly. So what's going on there is typically with a spin echo pulse sequence, we're limited in how many slices we can get in a TR period. So say we can only get 15 slices during one TR because of SAR reasons, but with a gradient echo pulse sequence, we're not really limited with that because we don't have all those extra RF pulses. Remember, RF pulses, we're putting energy in the patient. But with our gradient echo pulse sequence, we really only have one RF pulse, that initial variable flip angle excitation pulse, but we don't have that 180. So we don't have to worry about SAR limits as much. So we're able to get more slices in a given TR, which reduces our scan time. So an advantage of this, image with a much shorter TR overall. We go from 700 milliseconds, which is maximum for a T1 weighted image, down to below 20 milliseconds. We have that capability now. No real disadvantage with this. And the last characteristic, we have an alpha flip angle. Not 90 degrees. Is it going to be more or less than 90 degrees, do you think? Typically, less than 90 degrees. Due to saturation issues. What is saturation again? What's partial saturation? Greater than 90. What's complete saturation? 180. And with this saturation issue, we start to develop a concept called the steady state. Has anybody read that in the book? the steady state. It's one of the harder concepts to understand, but we'll go over that today. But the steady state came about because our TRs are so short in gradient echo pulse sequences, we need to create a flip angle that's less than 90 degrees that still gives us good signal from those tissues. So we maintain a steady state of energy in compared to energy out. So we actually have a flip angle that's about 30 to 45 degrees. And then we have a TR that's usually below 50 milliseconds. And we maintain that steady state. And that's usually what our parameters are going to be for our gradient echo pulse sequences. So does everybody have this written down? I can save it. All right, so let's go back to our presentation now. And let's start with our gradient echo pulse sequences. All right, so here is some common acronyms of our gradient echo pulse sequences that you're going to see out in clinic. You have the manufacturers up top here. So you have your GE, Philips, Siemens, Toshiba, and Hitachi. So you're really only going to be concerned with GE, Siemens, and then Nick, you're at your Hitachi site, but it's eventually going to change to Siemens. But here is a good list of all of your gradient echo pulse sequences we're going to talk about today. So today we're going to be going over coherent. Incoherent are also called spoiled gradient echo pulse sequences. Reverse echo gradient echo, sometimes it referred to a steady state free precession. A balanced gradient echo, and then we're not going to go over fast gradient echo, but echo planar imaging, EPI. Have you guys remember me talking about an EPI? Do you remember which pulse sequence within the brain was an EPI? A very fast pulse sequence to catch pathology. What was that very fast pulse sequence? In the brain. Just list the pulse sequences of the brain. DWI. That's the one that's going to be. Diffusion weighted, because remember, we're trying to catch water diffusing in the brain. And we're trying to see if there's any restricted diffusion. So we use an echoplanar imaging where we're scanning very rapidly to try and catch any restricted diffusion within the brain. And the main one is going to be during your acute strokes. So EPI, diffusion weighted imaging. Always relate those. So we've talked about a couple of these things already, but I just want to go over them again. So with your conventional gradient echo, compared to spin echo, we're using a variable flip angle. And what's the sign for variable flip angle? Alpha. That's usually less than 90 degrees. So that TR and scan time can be reduced without producing saturation, pushing those vectors past 90 degrees. A gradient is used to rephase our free induction decay instead of the 180. We can apply those gradients faster and at stronger amplitude. Therefore, minimum TE can be reduced. So now your TR and your TE can be reduced. The only drawback to gradients rephasing the spins is it doesn't compensate for these things. Magnetic field inhomogeneities And then what are the other two? Chemical shift. And I keep writing these down because I guarantee you this is a registry question. These three things are always going to be a registry question of what a gradient echo pulse sequence cannot correct for. And so the resultant echo displays a great deal of T2 star information. So take notice of this. Anytime we're talking about a gradient echo pulse sequence, it's no longer just T2 weighted. It's T2 star weighted. Another benefit of a gradient echo pulse sequence compared to spin echo, it's very sensitive to flow. We're actually able to image angiography with our gradient echo pulse sequence. So all those ones where you're doing those time of flights, you're timing your contrast. Have you guys done the carotid studies where you're watching the contrast go up the aortic arch and then go into the carotids? You're timing those things. You're trying to catch that blood flow in those arteries at this specific time. Those are your gradient echo pulse sequences because they have to be fast and they image flowing blood. Spin echoes are not going to be able to catch that flowing blood because it's a lot slower. So gradient echoes are very sensitive to blood flow. And the reason is our gradient rephasing is not slice selective. We don't have that 180-degree refocusing pulse, which is at a specific time. So if a spin gets excited but doesn't get rephased, it's not going to produce any signal on your MR image. If it gets excited and then it gets rephased later on by the gradients, it will appear bright, have signal within that vessel. So that's why our gradient echo pulse sequences are always the pulse sequence of choice when we're imaging angiography. Did everybody write that down? So this slide deals with your variable flip angles, your alpha flip angles. They're going to be less than 90 degrees. And that's because we're concerned with saturation issues. Our TRs are so short, we don't have enough time for those tissues to recover before the next flip angle happens. So what we do to compensate is reduce the flip angle to reduce saturation effects. So our flip angle is going to be less than 90 degrees, which is not ideal when we're trying to get a lot of signal in the transverse plane. Because remember, if it's less than 90 degrees, our vector is not going to be as large as if it flips completely into the transverse plane. But it's good in the sense that we'll get more signal depending on compensating is a better word for our shorter TRs. Short TRs require shorter flip angles. So here are our parameters for our conventional spin echo versus our conventional gradient echo. So take notice. So here we have a long and long. What is that, a T1 or T2? T2. So this one right here, we can say T2 weighted. And then obviously this one's going to be T1 weighted, short and short. Our flip angle is going to be the same, 90 degrees. But look at our gradient echo pulse sequence. Look at how low we can get our milliseconds for our TR and our TE. A lot less. So which one do you think is which? T1 or T2 here? The top one. What do you think? It's T2. And then the bottom one is T1 weighted. I screwed up something here. It's not T2 weighted, it's T2 what? Star. So I'll just draw it in. So we have star. So remember, anytime we're talking about a gradient echo pulse sequence, we need to add that little star because we're not getting a true image of T2 contrast. T2 star. So this next slide is just talking about how the gradients dephase and rephase. So we know we have gradients running in all three orthogonal planes. Our x plane gives us what slices? X. Sagittal. Why? This is the one Nick had to write down for his the review. What's y? You got sagittal out of the way. Just guess. Y is coronal, and z is axial.
Oh, you meant y. I thought you meant like y. Yeah.
Oh yeah. I wasn't asking a question. You got the first one right. So here you can see that we have an RF pulse, which is a variable flip angle. Then our gradients are going to dephase the spins first. And then it's going to rephase the spins, and we sample it at still our peak amplitude TE. So what's happening in these dephasing and rephasing is just we're switching the polarity of our gradients. So here you can see on our image on the right that our spins are coherent to start with. We have a very homogeneous field strength. Then we apply a gradient, let's say in the Z direction, head to toe. We have a stronger end and we have a weaker end, and you can see how the phases dephase. You have some going counterclockwise, we have some going clockwise. Then we rephase our spins, so we turn the gradient the opposite polarity, and what happens with those counterclockwise spins, they start to go back in the other direction towards towards 12 o'clock, and then the spins going towards 3 o'clock go back towards 12 o'clock too. So they go from incoherent to coherent spins again, because we want coherent spins because that's going to give us the greatest amount of signal, our highest signal amplitude. So that's what's happening with the gradients dephasing and rephasing. And remember, this is less efficient than our 180-degree refocusing pulse, but a lot faster. So let's talk about T2 star decay versus T2 decay. So you can put on this right above it. This also deals with T2 star weighted, and this deals with just T2 weighting. So with our T2 weighted, which we've already covered in the last semester, let's start with that one. Our spins, after our 90-degree excitation pulse is turned off, they start to decay. And they decay pretty much down to zero. Zero signal from those spins. But then we apply this 180-degree refocusing pulse at half of TE, and then they slowly start to rephase until peak amplitude, and then they start to dephase again. So you can see here, by the time we select or we read out our signal, our phases, our spins have regrown. That's going to be different compared to our T2 star. Our T2 star, this in blue, we have our 90-degree or even less flip angle. We turn it off, and then our spins just rapidly dephase. We do not have that 180-degree refocusing pulse, so this is where it's going to be at the same time. Almost nothing. It does regrow a little bit due to those gradients, but nothing compared to how high that signal gets with our 180-degree refocusing pulse. So we're getting T2 star decay due to the three things. What are those three things? Field inhomogeneities, magnetic susceptibility, and chemical shift. Always relate T2 star to those three properties. So anytime you're describing T2 weighting in gradient echo, you have to add on that little star. Here's a couple good diagrams of how gradient echoes are sensitive to flow. So here is a diagram of spin echo, and we'll cover this more in the next chapter on flow phenomena, but just to kind of give you a brief introduction to it, with our spin echo pulse sequence, remember we're governed by our 90 and 180, so we're limited in the timing of those two things. So we have flowing blood. This is a vessel going through a slice. This is our slice thickness. Let's say for a brain it's 5 millimeters, right? That's typical brain slice thickness. MSK, it's like around 3 or even less. So this is 5 millimeter slice thickness. So say we have that blood, that hydrogen proton within that red blood cell. It gets excited by that 90-degree excitation pulse. But then this little red blood cell has left the slice by the time before we can apply the refocusing pulse. So see how that signal from that spin decays, but it never regrows because it never had that 180-degree refocusing pulse, so it never actually regrows. So this little red blood cell gets zero signal on your MR image. But all the stationary tissues, which are outside the vessel, are going to get excitation and refocusing. But any type of moving spin is not going to get rephased. Okay? So this is why spin echo is limited in being able to visualize angiography. But here on the gradient echo side, we're not slice selective with our 180-degree refocusing pulse because we don't have a 180-degree refocusing pulse. The gradients refocus the spins, and you have gradients along the entire length of the bore of the magnet. So imagine if you are starting your slice at your feet, your ankle, and you have a flowing blood coming from your ankle, and then by the time you rephase it, it's all the way up, say, back at your heart. It doesn't matter because you have gradients along the length of the entire scanner to catch that flowing blood and to rephase it and give it signal within your MR image. So gradients are way more sensitive to flowing blood. So that's why we're selecting gradient echo pulse sequences when we're doing angiography. All right. So we've already kind of introduced this a little bit, talking about your TRs and your TEs with gradient echo pulse sequences. But there are three different processes that affect image weighting in gradient echo pulse sequences. The first one is extrinsic parameters. Extrinsic parameters, those are things we can control or not control. Those are things that we can control. And the three that are going to affect gradient echo weighting are TR, TE, and flip angle is going to be a big one. The second process is the steady state. We'll talk about that. And the third one is residual transverse magnetization. So in the steady state, usually we have some longitudinal magnetization and we have some transverse magnetization. And we get residual transverse magnetization after repeated TRs. And what we do with that residual magnetization will determine the image weighting of our gradient echo pulse sequence. One thing kind of remains the same with weighting. TE controls T2 star contrast. So TE was the main parameter that controlled T2 weighting on a spin echo. The only difference here is now it's just T2 star. So TE controls T2 star contrast. TR and flip angle. So now we add in flip angle control T1 contrast. In the past, when we've been talking about spin echo, it's only TR that was the main parameter that controlled T1. T1 weighted is maximized when a combination of TR and flip angle cause saturation of the vectors, so past 90 degrees. T1 is minimized when the combination of those two parameters does not cause saturation of the vectors. All right, so here is another diagram of a conventional gradient echo pulse sequence where we have variable flip angle, we dephase and rephase the spins, we sample it at TE, and then the process repeats itself. Very similar to our spin echo, but the only thing we're really lacking is that 180. So here are the parameters for T1 weighted, T2 star weighted, and proton density weighting. So with T1 weighted, we want to avoid full recovery of our longitudinal magnetization. So let's draw that out again. So our T1 curve looks something like this. Where we have fat recovering very fast. We have water or CSF recovering a lot slower. So to maximize T1 weighting, we need to avoid full recovery of these tissues, because if they fully recover all the way up here, there's not going to be any difference between those two tissues. So we need to select a TR that is shorter, so less than 50 milliseconds. And we need to have a larger flip angle. Larger flip angles, if we flip it closer to 90 degrees, like 70 degrees, you'll have a longer period and those tissues will recover at different rates, and you'll see a greater amount of contrast between those two tissues. So for T1 weighted, we have a larger flip angle and a short TR and a short TE to minimize T2 star. If we need T2 star weighting, we almost do the opposite for our flip angle. Now we have a short flip angle and we have a long TR and a long TE. But just notice the times, because they're different from your spin echoes. They're a lot shorter in general. And then proton density, remember, we're just concerned with the hydrogen spins within the tissue. We don't really care how those tissues relax. So we're going to minimize both T1 and T2. So we're minimizing T1 and minimizing T2. So our parameters reflect that. So we have a short flip angle, a long TR, and a short TE. Any questions so far? All right. So now let's describe this steady state. I feel like I have to kind of stand up for this one because we really have to talk about those vectors. So if I have two vectors, which vector is this? What do you think? This one aligns with B0, which is our static magnetic field. Which vector is this? MZ, which stands for what? Longitudinal or transverse?
Oh, longitudinal.
Longitudinal. So longitudinal. And then transverse, which is M sub what? XY. So M sub Z, M sub XY, longitudinal, transverse. All right, in the steady state, what's happening is to get maximum signal when we have a really short TR, we have to reduce our flip angle. And we're putting our flip angle about 30 to 45 degrees to get maximum signal for a steady state. So what happens is we apply energy into the patient, we flip it 30 to 45 degrees, we have some transverse magnetization, but we still have some longitudinal magnetization. Anytime you have flip angles less than 90 degrees, you maintain some of that longitudinal magnetization. So after about 3 or 4 iterations of our TR, where we're getting it, and then signals decaying, signals regrowing, we actually maintain this steady state where the flip angle stays constant and the amount of residual transverse magnetization is equivalent to the longitudinal magnetization. Okay? So we're putting energy in, which is our RF pulse. We're exciting those hydrogen protons, but then we're losing energy. Remember, tissues are regrowing, so they're losing energy to the lattice. Spin lattice. Remember, spin lattice is always associated with T1. Spin is associated with T2. You're losing energy to your neighboring spins. So therefore, critical values of flip angle and TR are required to maintain that steady state where we have equal amount of transverse magnetization, equal amount of longitudinal magnetization. So they coexist. But the only drawback to that is we have this residual magnetization after each TR. And what we do with that residual magnetization will determine whether it's going to be a coherent gradient echo, incoherent gradient echo, or our reverse gradient echo. Okay? So the definition of the steady state is a stable condition that does not change over time. So we're having a stable condition where we have residual transverse magnetization, we have longitudinal magnetization, and our flip angle is going to be 30 to 45 degrees every time. There's a scientific comparison where we actually heat up, say, a boiling pot of water. It takes a little while to get that pot of water boiling, so we're putting energy in, but then once that pot of water has started to boil, you maintain that heat, and then you're getting the water boiling, and then you're getting evaporation and things like that, so you're maintaining a steady state where that water doesn't get any hotter. Okay, you're putting in a lot of energy, that water doesn't get any hotter, and you're actually maintaining a steady state with that scientific comparison. That residual magnetization that stays on that transverse plane, sometimes it gets spoiled, meaning it just gets decayed real quick, or sometimes it gets rephased. Anytime it's rephased, it's called a stimulated echo. So this is a big term with gradient echo, stimulated echo. If you see that term, always associate it with gradient echo pulse sequences. Our echo that's created by our spin echo, where we have a 90 and 180, is called a Hahn echo. So a Hahn echo is a result of a 90, 180. And that is always going to be associated with our spin echo. So our resultant image in gradient echo is a ratio of T1 and T2 times and whether the free induction decay and or the stimulated echo are sampled. So I'll go over that a little bit more with these diagrams. So here is another drawing of our steady state, where we have our longitudinal magnetization. It flips into the transverse plane, but since our flip angle is less than 90 degrees, this vector is not as large as it could be. Our tissues decay and relax, and then we have another TR. And that TR, we have the same flip angle each time, and after 3 or 4 iterations, we maintain this steady state where we get this residual magnetization. This is that residual magnetization that stays on that transverse axis. A stimulated echo is created by 2 RF pulses. So your Hahn echo is created by a 90 and 180. In gradient echo pulse sequences, you don't have that 180, so you have 2 variable flip angles, which are denoted as alpha. So anytime you have 2 RF pulses that are less than 90 degrees, you're creating a stimulated echo. So the stimulated echo in this diagram is in red. So you have your first RF excitation pulse, which is less than 90 degrees. You get your free induction decay. You have a really short TR period. Then you have your second excitation pulse. You get another free induction decay. But this second excitation pulse actually regrows your first free induction decay. So this that's decaying is now going to regrow, and due to the timing of our TRs, it's going to regrow as you're going to be exciting the next slice. Okay? So you have your third excitation pulse, where you have your free induction decay and your stimulated echo are going to be laying on top of each other. So this concept is how we describe our gradient echo pulse sequences. Whether we just sample the free induction decay and the stimulated echo, or just the stimulated echo without the free induction decay, that's how we're going to get coherent, incoherent, and reverse. So our gradient echo pulse sequences key point is classified whether the residual magnetization is in phase, coherent, or out of phase, incoherent. All right, our first gradient echo pulse sequence is called coherent gradient echo. So that means our spin's going to be in phase. So anytime you see the word coherent, always think of in phase. So that residual magnetization that's sitting on that transverse axis, we want to incorporate that into our signal. So it has slowly started to decay by fanning out. So we apply a rewinder gradient to reverse the fanning out of those spins so they come back coherent. So that transverse magnetization is rewound so the spins are going to be coherent. So we collect the signal from the residual magnetization, which is now coherent, and the free induction decay. So we have a stimulated echo and the free induction decay that we're going to have within our resultant echo. So our parameters, we're maintaining that steady state. So we have our flip angle 30 to 45, and our TR is going to be short, 20 to 50 milliseconds. But this pulse sequence is usually used for T2 star weighting. So the only thing we really change is our TE, and we want a long TE to get T2 star weighting. So in coherent gradient echo, we're rewinding those spins in the residual transverse magnetization, and you're going to incorporate not only the stimulated echo, but the free induction decay. You want to keep your TE long because you're going to maximize your T2 star weighting. So coherent gradient echo is typically going to look like a T2 weighted sequence. So some advantages and disadvantages. Advantage, very fast scan times. You can do a breath hold, sensitive flow for angiography, and you can acquire volume acquisitions. Disadvantage, you're not going to have as much signal, magnetic susceptibility increases, and you have loud gradient noises because those gradients are being applied very rapidly and at very strong amplitudes. So this is what a coherent gradient echo looks like. So coherent, once again, means in phase, and you are going to associate it with T2 star weighting. So how are you able to tell this is a T2? Where do you look? Where's the fluid? In the aorta. Where else? Spinal cord. So you do notice the difference, though. He said we have high signal in the aorta, descending aorta, because we're sensitive to blood flow. So we're going to get signal in those vessels. So you have high signal within the vessels, but then you still have your high signal within the spinal cord. So this is a T2 weighted. But just look at the overall image quality. Do you normally get these rings around the organs? You don't. That's actually a concept in and out of phase, and usually on the out of phase imaging, you get these rings around the organs. So our image quality is not as good. But we're able to image angiography, and we get an image that doesn't have any motion on it. Because we're imaging the abdomen, and our patients are breathing, and they can only hold their breath for like 20 seconds. And I'd rather have an image with a little bit lower quality compared to having one that has a motion artifact streaking across the image. So our coherent gradient echoes, these are the acronyms for your manufacturers. For GE, it's GRAS, Siemens, FISP, and then Philips is FFE. And if you need to remember what those are, just go back to your initial chart at the beginning of the unit. You can see all what they stand for down here. All right. So now we have incoherent gradient echo. So incoherent is associated with what? In phase or out of phase? Out of phase. So our residual transverse magnetization that's been sitting on that transverse axis is going to get further decayed. We're not going to rewind the signal. We're going to actually dephase it even more by what we call our gradient spoiling. So a lot of times this incoherent gradient echo is also called a spoiled gradient echo. Because we're using gradients on the slice select, frequency encoding, and phase encoding gradients to further decay that residual transverse magnetization. So we're spoiling that residual transverse magnetization. There's two ways to achieve spoiling, RF spoiling and gradient spoiling. Most of the time it is this gradient spoiling where we're using the different gradient axes and to further decay that residual transverse magnetization, but sometimes you do RF spoiling. Here the resultant echo contains only information from that free induction decay. So we do not include information from the stimulated echo because there's no more transverse magnetization to be refocused because we've decayed it completely. So we don't have any of that transverse magnetization that can be rephased. So it's only gonna enable T1 contrast to dominate. So if you always want to associate incoherent or spoil gradient echo with T1 weighting. So our parameters, we're going to maintain that steady state, so our flip angle and our TR are going to be the same. But now our TE is short compared to long because we want to maximize our T1 weighting. So we're in spoiled gradient echo, we're further dephasing that residual transverse magnetization. Some advantages, once again, we can do breath holds. We can acquire it in a volume acquisition or 2D. Typically that vibe sequence, have you guys, the lava for GE and the vibe sequence, those are going to be your volume acquisitions. That's where you're acquiring it in 3 dimensions. And you can do your subtractions off your vibe sequences. This can be used after gadolinium contrast. That's because it's a T1 weighted. So most of the time when we're injecting contrast, we're only going to be doing T1 weighted imaging. Sometimes at Emory protocols you do T2s because just to kind of save time post-contrast. But most of the time you're going to have T1 weighted images when you inject contrast because your lesions are going to appear bright on your T1 weighted. Disadvantages, poor signal, magnetic susceptibility, and loud gradient noises. Those are the same disadvantages. So here's an incoherent gradient echo of the brain. Say you have a patient that's kind of moving all over the place during your brain scan and you want to reduce the amount of time. Throw an incoherent or spoil gradient echo in there so it's a shorter sequence and you get an image without motion artifact. The image quality is not going to be as good, but you're still going to be able to see what you need to see within the brain. Have you guys used the blade sequence for patients that move side to side? Have you guys seen that yet? That helps to reduce motion artifact going right to left when the patient's kind of just wiggling their head during the scan. Usually it's like inpatients like Kiara, where you're at the main hospital, they'll throw in a blade for those patients that are maybe sedated and they're just doing slight movements and you can't do anything about that, okay? So here are the acronyms for our incoherent gradient echo. So once again, also called spoiled, and it's going to be a T1 weighted. All right. The third gradient echo that we're going to talk about today, and then this is kind of where we'll stop, just to kind of give you a break, and then we'll go over procedures. I don't want to fill your heads up with too much gradient echo stuff today. It's called the reverse gradient echo. It is sometimes referred to as the SSFP, which stands for the steady state free precession. So there's a general move to change the name to reverse gradient echo because the steady state is a concept you've already kind of tried to learn. And then now calling this pulse sequence the steady state free precession, it can be quite confusing. So they've changed the name from SSFP to a reverse gradient echo. here, we are actually going to have the resultant echo only containing information from the stimulated echo. So we do not want information from our free induction decay. But due to the steady state, usually the echo occurs right over the free induction decay. So how do we separate the two? What they do is actually apply a rewinder gradient, which speeds up the rephasing of the stimulated echo. So you have one excitation pulse, second excitation pulse. Then you have your rewinding gradient, which speeds up that rephasing so that the stimulated echo occurs before that third free induction decay, not over top of it. So now we've separated the two, and then what we're going to do is put our readout gradient over the stimulated echo, and we're not concerned with the free induction decay. So this will include more T2 weighted information, not T2 star, because we have two RF pulses dephasing and rephasing compared to gradients doing the rephasing. So it's going to contain more T2, just general T2 information compared to T2 star information. So you are going to have a TE that is as short as possible to enhance T2 contrast. And you actually get two TEs with this gradient echo pulse sequence. You get your effective TE from your first excitation pulse to when the actual stimulated echo occurs. And then the TE from when it normally should be occurring right here, but due to our rewinder gradient, it occurs a little bit earlier. So we actually, this TE is our second TE, is the time that it has reduced, and it occurs a little bit sooner. So to get the effective TE on your reverse gradient echo, it's actually due to this formula. 2 times TR minus the actual TE, which is this one, your actual TE. This is your effective TE, this is your actual TE. The effective TE is the one that you set on your console, but it's not the actual image contrast that you're getting. So the main thing we want to remember with this is you're going to be using a rewinder gradient to have the stimulated echo occur sooner, not over top your third free induction decay, so that you can sample the signal just from that stimulated echo. It gives us more true T2 weighted, not T2 star. So advantage, we get truer T2 weighting, achieve then conventional gradient echo, and then your disadvantages are all the same. So here is an example of a reverse gradient echo. So look at how just the image looks in general. We have very high signal from our CSF. We have signal from that descending aorta again. We have muscle appears dark. So it's truer T2 weighted information. Here are our acronyms for the different manufacturers. So for our first unit on gradient echo, let's stop there. Do you guys have any questions? I know that's a lot of information. Sometimes on the registry, you don't really need to remember the rewinding, the reverse, those things like that. The main thing you need to know is like an incoherent gradient echo is T1 weighted. A coherent gradient echo is T2 weighted, T2 star. So it's really just kind of like I did with that review game. It's really just associating things. Not really, you don't have to memorize these concepts. Just being able to associate things is the key for when you take the registry and when you take my test. All right, so I'll stop the recording here and let's do a 15-minute break, and then we'll go over spine procedures.